Uh, the aesthetic evaluate through the soft tissue, not the bone tissue. So most of our parametric analysis is focused to the bone. But my opinion is we expand analysis to outside, yeah, it means soft tissue. Do you understand? So I always talk about soft tissue to get facial beautiful aesthetic. So I divided it three different characteristics in the face. So in the upper face is here, okay? And this is lower face. So in upper face, everybody understands what is the nasolabial angle. So nasolabial angle is most well-known analysis method to evaluate upper face, okay? So nasolabial angle is most common one. But I added two different things. One is labial thickness. It means lip thickness, okay? According to the lateral separagram. And another one is labial vertical. Labial vertical is the point nasal, nose and labial. We can get point at here, okay? After nasolabial angle is the angle between nose and labial, upper lip, just angle. But I think if we want to get more aesthetic face, the angle is composed like this, but we need vertical line just after the contact. If they don't have any nasolabial angle is correct within normal, but my patient didn't show labial vertical. Labial vertical, okay, I will talk it about here. So this is, I call it labial vertical, okay? The angle between this line and this line, okay? We call it nasolabial angle. But if patient do not show labial vertical, it means labial vertical means this line, okay? So angle didn't explain about the real aesthetic one. So labial vertical line is really important to get aesthetic face, okay? And then in low face, labiomental fold is almost this angle, this line and this line is a common one. But they didn't check chin thickness. Chin thickness is this one, okay? So in low face, I usually think about the thin thickness and chin vertical also. Chin vertical is this line. This line is vertical or inclined, okay, or proclined. It's very important to get aesthetic face. So chin angle, another one is chin angle. Soft tissue, evaluation of soft tissue first, and then second one is evaluation of chin shape. So it composed by parietal plane and vertical line to the parietal plane. And then another line is chin line, we call it infradentale, the point in the bone, and Pogonian. Okay, infradentale to Pogonian line, this line. So we can evaluate the angle between vertical, okay, angle between lesion vertical line to parietal plane, this line, and another line is this line. Its mean is 12 plus minus 3. So if this angle is outside of normal limit, we call it unesthetic bone structure. Okay, so if patients show unesthetic bone structure, at that time orthodontic treatment never get aesthetic phase. So bone structure and soft tissue is permanent one. It doesn't control by orthodontics. Do you understand? Okay, soft tissue and bone structure, we cannot rearrange it by extraction therapy or pushback therapy. It depends on another method. Okay, so chin angle means this one. 23 is larger than normal range. It means we try to move anterior teeth back because this patient complain about protrusion. Okay, but we use extraction space very, very efficiently. Okay, so we move whole anterior teeth back without any ankle loss. At that time, that is the best result for 2D extraction therapy. But aesthetic is not good. The reason why bone structure is not aesthetic. So we need to explain it to parent and patient before we start. You understand? So let's make what is that? Drawing. Okay. Let's make compare to patient imagination after orthodontic treatment, and let's doctor's imagination. Let's compare both of them. So the parent usually think about more aesthetic face, but doctor didn't think because this patient has a real aesthetic construction. So we need to match each other. And then we start treatment. If you don't match each other, and then your treatment finished, after that, they means parent and patient complain. So before you start your treatment, please match my imagination and patient imagination. So this we cannot control this one. But if patient want to more, okay, let's say patient understood my opinion, and then patient eager to improve even though their structure like this. At that time, we need to recommend another approach with orthodontics. Okay, so most common one is we need to advance chin. it's a really a good advice to the patient. So cut at here and advance chin surgery. That is one option. And another option is implantation at here, okay, to make chin. So before we start, we talk each other and we recommend another approach. Okay, do you understand? So separametics look at this patient. This patient looks like severe protrusion, upper protrusion. This patient want to move this teeth back, okay? But look at patient structure, okay? So patient think after orthodontics, he will be aesthetic face, but it's wrong because let's start to evaluate patient bone structure, okay? So we need the parietal line like this. So we need to turn this X-ray to get matched with parietal line. So these same separometrics, but match at parietal line. This is not matched to the parietal line. So we need to turn in the screen. So in the computer screen, we can turn it to match horizontal line. And then look, this picture show me upper protrusion, okay? Mandible looks like normal, but when we change this picture to like this, what is the problem? No, mandible is not aesthetic structure. Really bad structure. So let's check this line, infradentale and pogonium. Check the angle. The angle is 31. It means this patient has permanent ugly structure. But patient wants to look nice after premolar extraction therapy. It's wrong. But this is not my case, okay? My student case. And he extract upper 4 and lower 4 and retract. The mechanics is too difficult. And then he already understand the 3 different skeletal anchorage of me. So he's very excellent to use. Yeah? C implant, C tube, and C part plate. So he believed that. So that material will be change these faces is good. But I think this is not good bone structure. We cannot get aesthetic without another approach. Do you understand? So the aim of separometric evaluation is that, okay, the score is no information to you. Just evaluate that this patient show aesthetic structure or non-aesthetic bone structure. And this patient show thick soft tissue on thin soft tissue. Okay? So my focus is that. So look at here. This patient really want to cut and rotate. Yeah? Mandible advancement surgery is better because his occlusion is very nice. Okay? But extract this one and retract. So let's look. So if I was his doctor, I recommend genioplasty. Advanced genioplasty, okay? Advanced genioplasty is better, okay? Advanced genioplasty is better, and it is really good result without any uncomfortable 3 years of orthodontic treatment and uncomfortable chewing and uncomfortable brushing and uncomfortable viewing. So just genioplasty is good to him because his chief complaint is aesthetic improvement according to the orthodontics. He doesn't know about the potential of orthodontics. Okay, so advanced genioplasty is good. Okay, so after his treatment, okay, I'll be there. So another patient from Mongolia is waiting outside. So this is after the orthodontic treatment. But I think a lot of effort, the result just like this. If you like this, yeah, patient like this, because his face, look at here, vertical, labial vertical, we achieved. And then chin vertical is here. And then what is the main result of this face? Because soft tissue is thick. Okay? Look at the shape of soft tissue is not good. Okay? Shape of soft tissue is not good. And then upper for lower for extraction treatment. Look at sometimes the soft tissue start to change because if patient has a habitual contraction around here, the retraction of lower anteriors will be released. That look at this patient. The structure is not so good. Okay. Look at another factor. This patient is not good bone structure, but the square is better, more worse than this patient. This patient's score is 23. This patient is 32. Okay, this is more ugly structure. But look, let's compare both of them. Okay, so this is more severe. But look at this patient is really thin, soft tissue. This patient really thick, soft tissue. so the face compensate. Okay, so please check soft tissue, bone structure plus soft tissue always. So soft tissue, thick soft tissue is good to orthodontic result. Okay, especially in chin. So upper for lower for extraction treatment, the face improved but not aesthetic because this is too thin. Okay, this extraction therapy is almost improved a little bit because only there is here is enough bone thickness, so there is no uh, good in advancement at here, but only this line. Okay, so this vertical line, this the angle is same, but this picture has a little vertical line at here. So please check every face with angle and then thickness. Which one is better after orthodontic treatment? This one. Okay, more thick. Enough soft chin thickness is really important. So this patient has enough, and so enough bone thickness is always good to orthodontist. This patient, look at this patient. Enough? It is the chin angle is not the a little larger, but this patient chin angle more bigger than before, but look at this is more good bone structure, but two patient difference is chin angle is this patient is a little larger. Okay, let's go back. This patient 17, this patient is 20. After orthodontic treatment, weak soft tissue thickness, but mechanics same, but result, aesthetic result is no good. Okay, aesthetic result is no good. So aesthetic is better because even though she showed more big chin angle. So look at this surgery patient. Okay, class 3, and did surgery like this. But if I'm a oral surgeon, I'll do chin advancement because this patient really bad profile, okay, bad soft tissue. So after surgery, no good, okay? But sometimes it's too, the bone structure is advanced. And then soft tissue is still thick. Is not advanced a good combination. Okay? So, and this time we need to grind chin angle. So let's talk about upper nasolabial angle and labial thickness. This is labial thickness is really thick compared to this one. So look at labial vertical and then comfortable labial thickness. But in this case, labial thickness is too strong. We cannot control that. Okay? So labial thickness, please think about labial thickness also. Okay? This patient, basically labial thickness is too big. So look at labial thickness. So please evaluate soft tissue. Okay? Chin vertical. There is no, we call it no chin vertical. Chin vertical is like this direction. Labiomental fold. Okay? This one. Chin vertical. And another one is chin thickness. So please think about chin thickness. Okay? So if patient chin thickness is not strong, so genioplasty or chin augmentation. Add something at here. Look at the structure. The structure is, basic structure is really bad, but patient wants to improve aesthetic. So another approach is genioplasty is hard under the local anesthesia. So instead of genioplasty, we move lower anterior section back by what is that? Segmental osteosurgery under local anesthesia. So this patient, we did segmental, yeah, segmental setback under the local anesthesia. So in the upper teeth, we extract for and retract, and then lower, we cannot improve aesthetic because this patient show uncomfortable structure already. So if we extract the lower teeth and retract like this, it is no good. Retract like this is better. Okay? Without any approach, orthodontic retraction usually like, okay, that is the result. But ASO is this kind of movement with this angulation. It's better. So we did that. Okay? Here. So the ASO will change the angle. Okay? So surgical approach, first one is advanced genio. And second one is ANS at here. But ANS of this patient usually continue under the local anesthesia. So let's look the facial aesthetic change. Okay, so please think about two different surgical approach. But this patient doesn't have enough money, and then we recommend to do. Look at, okay, very ugly Yeah, the the short chin thickness, the angle is 20. It's not severe, but we did, yeah, lower anterior cut under the local anesthesia. If you have those kind of approach to your patient, please refer them to the oral surgeon. A lot of experience, oral surgeon. That is my son-in-law. Okay, please send your patient to his office. He is well organized of that. So a lot of our members send their patient to him to do this cut. Okay. So oral surgeon, experienced oral surgeon usually can do that. So this is the result of ASO, okay, under local anesthesia, lower ASO. So we can get all different results, yeah, within good. So this patient looks like, okay, let's go back. This patient, initial, okay? So if you get real aesthetic improvement to your patient, think about this, okay? It's totally different phase. There is orthodontic limitation, so we need to overcome the orthodontic difference. Look at a little mentally retarded patient, but his face looks more ugly. So parents want to change. Look at it's a totally different. Okay, so this is my final approach. Okay, so I want to talk about that. This one is okay. Same patient. Okay, this approach. Okay, this is another one approach. Look at this patient occlusion is not bad. Occlusion is good. So I explain about this patient. Okay. So after the look at the face changed because this augmentation. Okay. So look at she increased chin soft tissue like this. Okay. Please send them to the plastic surgeon also. So your result, so this patient bad structure and thin, okay? So I refer her to the plastic surgeon to get this approach, okay? Please you don't need to orthodontic treatment. So the reaction according to orthodontic treatment is limited and your teeth will destroy. So I refer you to the plastic, yeah, surgery. That is our duty. Okay. In a young child, evaluate the structure with this short item, okay, and check the soft tissue, okay, and then don't try to extraction therapy. So wait, okay. This patient show crowding, okay, crowding. Cuts to division 1, a lot of overjet also here. Let's see patient panoramic view. So TM joint is no good. And the third molar is here, okay? But let's look at patient separometrics. So look at lateral separogram. This patient originally have uncontrolled bone structure, okay? So my student already understand what is the important factor. So he evaluate the angle and 45, okay? 25 is normal. 25 to 30 is normal, okay? But it's very, very bad, score. And this one is also really bad. So my student recommend her, you need surgery. Huh? And parent, no, patient and patient husband, we don't get surgery, okay? So they start compensation each other and then make treatment objective each other. So the treatment objective is upper anterior alignment only, okay? If lower anterior teeth to need some arrangement, so my student recommend to them, I will grind your anteriors and I will align it, but they didn't accept that. Grinding, no, okay? If short mandible, small mandible, if we extract premolar to control anteriors, the mandible will become more small. So holding all teeth is better to this patient mandible size. So my student, Dr. Park recommend stripping and align, but they reject that. So the target of this patient is to retract, align, and retract upper teeth with upper extraction. First molar extraction, first premolar extraction, okay? So please evaluate lateral separometrics with my method. It will be more strong, it will give you more strong opinion about orthodontic result. So it's very important before you start orthodontic treatment, okay? So separometric, the aim of separometric is real this kind of one. The score, FMA, SNA, and another everything is too confused. It's a simple one, but it gives you strong advice. Okay? So they agree each other. And then position C implant between 5 to 6. Okay, C implant. And then this is C wire. We call it CC wire. Combination of stainless steel and night tie. Okay, so if you order this, this is stainless steel section. Okay, this is night tie section. So stainless steel and night tie connected by specially formed tube. So if you want this kind of approach, you need to buy this one, this section, to the beach lab. Beach lab has a license to make that. But if you want to make this by yourself, you can do it. But beach lab already understand what kind of size is best one, and if you order this frame, okay, wire frame, you can buy it to them. So order, after that they start to make. So this is stainless, combination of stainless steel and night tie wire. Okay, so this is the beginning after extraction. And then most important one is retraction force to the hook. Okay, the length of hook, and if you prepare this stainless steel, what is this? We call it C. I'm not sure for C frames. I don't know, but the name they named. But anyway, there is an item to make this one, so they prepare the stainless steel rectangular wire to make this one, and then what is that? Clamping will do by yourself. So the side of clamping area is just behind the lateral bracket. Okay, so when you engaged the night tie arch wire like this, and then it is movable. After that, mark here and clamping there. Okay, is here a sample around here? So night tie wire usually I don't know the night tie wire size of this patient. I don't have any information. Maybe 16 by 22. Okay, 16 by 22 night tie wire, or sometimes 18 round night tie. But in this situation, the crowding is not so serious. So 여기 있어. You can okay. This is the sample. Okay. Okay. So I'll demonstrate it to you if you are interested in. And then let's look. The the beginning picture, okay, and take X-ray, look at the cuspid axis, the normal. 1 month after, power chain is still engaged. Power chain force is really important to the hook. The reason is if you didn't enough power chain force to the hook, the result of leveling will protrude from this outside. Okay? If we apply the power chain at here, it prevents labialization of centrals. Okay? And then the result, canine will move back. This is anterior anchorage concept by Dr. Root. Dr. Root, level anchorage system. He developed the level anchorage system technique. So, according to Dr. Root, if crowding is here in open dentition, and then when you apply more and more thick nighttime arch wire through the whole bracket, it means there is no angulation because heavy arch wire is inserted in the bracket. So there is no torque, no, the nighttime arch wire is full in the bracket. So these teeth cannot move outside, his opinion, because if you have a play between here, okay, leveling means always outside movement, okay? Leveling by nighttime means outside position of teeth, okay? Outside. But if you applied full size of nighttime arch wire at here until 7, yeah? Full nighttime arch wire. And then J hook around here, it leveling force is in arch wire, and leveling force will spread to the full upper teeth. But the result is move posterior teeth back instead of anterior teeth forward. Do you understand? That is the Dr. Root concept, and he called it A-point anchorage. A-point anchorage. A-point anchorage. A-point is here. If anterior teeth root just contact to the cortical bone with surface, okay? It means surface contact of root to the cortical bone is very strong. So leveling force will move posterior teeth back. Okay, that is the Dr. Root idea. So this kind of design comes from Dr. Root idea. You understand? If you don't apply power chain force to the hook, this leveling force will move from teeth outside. Okay? You understand? Sometimes one of my students apply instead of this one, apply this one. Okay, it's wrong. You understand? Don't apply power chain to the cuspid. He think, huh? He think, another student think this kind of movement will help the crowding, yeah? But it doesn't work well. It doesn't. It's a wrong direction. Will be make wrong direction. 3 months after. 3 months after. Look at the chain. Anterior teeth aligned well. Okay, and then look at the cuspid movement. Back. Anterior teeth leveling means there is enough canine distal movement. Okay. 3 months after, look at the evaluate. Please evaluate the cuspid. If you apply the power chain force to the cuspid, tipping will happen instead of this kind of movement. Okay? This is bonding error, I think. This is a little control we need of these laterals. But anyway, 3 months later, still there. And look at the bone line. Look at here, the root movement. Okay? Look at here. New bone formed with line. Five months later, mandible is still same, but in upper, almost 2/3 space, yeah, disappeared. 5 months after. 6 months after, he added, okay, from the, here is straight line, 3 months after, okay? And then look at gavel band at here. We already studied about intrusive force. When we need some kind of intrusive force, at that time we add gavel band. Gavel band at here. We already published those kind of research to the journal. So look at, there's no, almost all space disappeared. Look at the cuspid. Look at the cuspid. We didn't apply cuspid retraction force, okay? But cusp moved back because anterior is strong, okay? So leveling force is spread to the cuspid back. Look at, it's really, really important, really important mechanics flow to my technique. Look at, so leveling and retraction of upper teeth, this kind of approach is best, but it requires to buy this one, okay? So There is no more retraction at here because lower teeth contact. So just the treatment objective is align and retraction. That's it. No another, yeah, picture. No another picture they made. Okay. So this is real orthodontic. And then patient start to change to accept genioplasty. Maybe she did genioplasty, but I don't have any more picture of her, just this one. Okay, so please try to make more reasonable aesthetic with our skill. Okay. Okay. 야, 이거 시간이. This is another part. This is my student first approach to do ASO. Please check it carefully. At this moment, the control of breathing is really important. Incision under the uh, root level. Okay, so local anesthesia and relax, and then mark the cut line or incision line, and then soft tissue cut. When you start to cut soft tissue, it will create breathing point. So breathing point, you need cautery. Okay, just breathing and cautery, just breathing and cautery. Carefully control the breathing. And then this is initial cortical bone coating. according to line. So this is under the root apex. Okay, 4 or 5 millimeter lower than the root apex. Can you do it? Round bar, surgical bar. So just, okay. So look at here. Here is only horizontal incision only. Never try to vertical incision. Okay? Horizontal incision and make a flat, and you can cut, even though in the vertical. Okay? Don't please try to vertical cut. It's a broad circulation. We need to cut the bone without minimum of, okay, broad circulation stop. Okay, in the lingual area there is a broad circulation. Okay, full same. But in the labial area we just cut. So never cut lingual area, and then never cut vertical area. That is my opinion. Okay, so we can make flat and we can cut vertical. 연조지. Just soft tissue. Soft tissue means blood. Yeah, blood vessel. So you can do outline first. Okay, and then it's time to pass to the lingual. Okay, cut from the labial to the lingual. Keep cutting, okay, through the bar from the labial side. So labial bar is go deep, and then it will meet lingual bone, and then the doctor can feel, it touched the lingual area, and then start to cut, yeah, continue. But when the bone is cut already, he feel, here is a soft tissue. So during the cutting the bone, don't damage it to the soft tissue. Okay? 이렇게 다시 본 거야? 다 봤어? 이거 처음이야, 올가. The cutted line is 3 millimeter usually. Yeah? When we try to cut from the labial side to the lingual side, the depth is almost 2 or 3 millimeter. It's good to intrude section. And then use this kind of plate, so you can fix the movable part with X plate like this. So there is a rule. I made a rule. The section is usually need to intrude 2 millimeter. And then the lower part of section is need to move backward at least 4 millimeter. So 2 by 4 rule. Okay, cut section and the depth of cutted area usually allow 2 millimeter intrusion, and then most important one, okay, 4 millimeter. So don't think about the tooth position anymore. Just think about bone, yeah, movement. Okay, so please don't try to when you start to move this section back. At that time, a lot of doctor concern about the lower incisor ethics, but don't worry about that. Don't think about that. Just movement of section only. Okay, so work after the fixation and after the repair process, and then we can control lower teeth without any difficulty. So don't think the tooth position. Just cut.
단차가 생기면 하방 부분 혹시 다듬어줘요? 아니면 그냥 저렇게?
이거 어디 다듬느냐고? 다듬지 않고 leave that. And sometimes surge pack at here. surge pack 알지? 그거 있잖아. 그거 거즈 같은 거 있잖아. surge cell? So sometimes insert surge cell. And then here is 1 point fixation. It is not enough. After the fixation, the section can rotate. So another fixation is in the between the teeth and labor teeth with ligation. So 1 point fixation and ligation to the terminal part of section to the posterior teeth, and another here. After that, it will fix. Okay?
교수님 폐경 수술하고 나면 웨이퍼로 이렇게 붙잖아요. 웨이퍼로 고정을 해도
Vapor? We don't use any vapor.
하면 더 좋은 거 아니에요?
It's too complicated. We don't need that. Just move. You remind him. Okay? Initial. Terrible. Her brother, his brother. This is just after the ASO. The surgeon is first patient to do ASO under the local anesthesia. Okay? Look at, here is no space reduction. Okay? Still same space. Don't worry about that. Just think about lower line. Okay, so 2x4, and then bandage. So look at this doctor, oral surgeon. Okay, he experienced a lot of two-jaw surgery under the general anesthesia, but this is his first approach under local anesthesia. After that, automatically intrusion happened. Look at 2x4. So the doctor followed my idea because this is his first approach. In the upper, we attached syringal retractor right here. And then after that, May 3, almost 2 weeks later, we applied arch wire, night high arch wire. Okay, the bone is still not osteoed, but we apply arch wire. And in the upper, like this, and then look at, this is a little heavy arch wire to retract this section. Okay, and in the upper, extract first molar and place this one. So look at, it's a little strong one, but there is very energetic cell reaction is around there. So a little heavy force they can accept. So anyway, it's a ready-made 2 keyhole loop. It's a ready-made wire. And then look at the step at here. Because the intrusion already happened. So to keep intrusion amount, but more important mechanics is open the loop with cinch back and then try to retract anterior, lower anterior back. And then a lot of space disappeared. Okay? And then the result, retractional result, will override low anterior teeth. Okay? So at the beginning, there is a step, but at the final, we don't need any more step because of override. And then this is another night high arch wire. And then more retraction with this one. It's switch. Yeah? I didn't touch him. I just watch my student treatment procedure. Just okay? In the upper, retraction start. The bone will, the cutted area will take at least 3 months of healing period, more than 3 months. But under the 3 months, there is green, just like a green stick fracture situation. So we can retract, we can move. without any resistance. Do you understand? The phase initial and during the treatment, the phase change. Just after the treatment, look at. So almost upright without any problem. Look at the bodily, almost we push back the lower part back and upright anteriors. It means bodily nicely retraction. Just he took the picture. So after the cut, he applied night tie, and then after that, he think he need to retract section a little bit, and then control the navel, and then retract, and retract, control navel. But in the upper retraction, almost here size, a lot of retraction here compared to this area. And then he attached full fixed bracket in the upper. So look at this kind of, and then at here, he moved all retractor because it's a weak point. So the solder is separated. So he moved. So please, the very good soldering technique is we need. But in this case, if I am the student of this patient, I will, when I check the lingual area around here, I felt there is a weak area at here. At that time, I will tie the wire from here to here and here to here and tie here. So we can hold, we can reinforce the weak area with rigorous tying. And then we can keep retraction. But in this situation, it's so it's separate. So the doctor start fixed more earlier. Look at, and then leveling, continued in the upper and lower. The leveling procedure is not the common, because he tried to midline run, so he tried to move a little difficulty. So retraction and leveling continue, and retraction and leveling. So he's not, I think he's not well organized, the midline correction well. So a little round trip. is here. But anyway, he continue. So this kind of leveling so it takes time. But anyway, from here, the start surgery, and it takes 1 year and 5 months. And 1 year and 5 months later, two screw bicortical. So from here to here. So if you find weak point at that time, ligate it, and you can retract more, and then start leveling is better.
화학 ASO 할
네.
때 저희 집에서 한번 이렇게 또 환자를 보내서 이렇게 한번 해봤는데 한 번 하나 이렇게 신경이 하나 죽더라고요.
Sometimes they will cut the apex, or it's not common. Very few discoloration after. Okay, if there is no enough, okay, space, and the doctor, so it's acceptable, I think. This is another patient. In this file, all of these all cases undergone by my student. Okay. Look at class 3 key. So my student tried to push back lower teeth and then create space and then cut. That is my student idea. So he positioned C2 after extraction of third molar. Look at, okay? And then start to push back. So some space is here, but look at the ring arch is not good enough. But anyway, he made this ring arch by himself. And then you can see the space at here and at here. What is that? He did a little piezo, okay, to get corticotomia at around here. I think around here, maybe to practice or not. But I think his idea is to cut only 4 anteriors, changed his mind. So he tried to move cuspid back more. What is why he located open coil here? I don't know. But anyway, he tried to move cuspid back, but I don't understand why he bring this teeth back more, okay? But anyway, so he planned to cut only 4 anteriors, okay? But later he changed his mind. So it's a round trip, but because they are students, okay? So in upper, he attached sectional arch wire and tried to intrude posterior section a little bit. He tried, but look at space, yeah, consolidation at here, and then try to cut like here, okay? Sectional arch wire, it means full arch wire uh, is not uh, help to make fixation. So sectional arch wire. So sectional arch wire and sectional arch wire and sectional arch wire. 3 sectional arch wire. It's a preparation of ASO. He spent 1 year to move whole teeth back. Okay? And create space around here. And then ASO and bandage. Look at this is another student approach. hole, and then yeah, make it in a line, and then cut the lingual area. So most important trimming here is I will tell you about trimming of surface is really important when you try to push back. Okay, so if the cutted bone surface is rough, it's very difficult to position lingual. Okay, so the most important area is corner line. Understand? Corner line. So please smooth the corner line. So it's more easy to position back. And then here's space. Yeah, still here. And then this patient has a tongue, lingual frenum is too tight. So lingual frenum control. So look at here, a little cutting line at here. Okay? But in the cuspid is sound. And then sectional, fixation at here, and ligation at here, and ligation at here. After ASO, okay? 1 month after, a little swelling is still, but there is no more record after that. What is that? This is another case. CC is lower anterior protrusion. Brachyphase. So control of lower space to make collected space around here. So look at. So finally, all space collected at here, and then it's easy to cut because the root is short. Okay, long root is difficult to cut. So check the patient root. So I don't understand why this patient didn't have a sectional arch wire. But anyway, there is no sectional arch wire, just a retraction arch wire instead of ligation. Okay, so full continuous arch wire at here. So this is arch wire engaged like this. After surgery, the crossbite is still there. Okay, it's unbelievable result. Most of oral surgeons finished their ASO with good anterior relation, but it is not possible in the operating room. So they usually to make ring version. Okay, do you agree with my opinion? Always ring version, because the surgeon usually try to close the space, but it is not easy in the operation room with ASICs. The aim of ASO is like this kind of retraction, but it is not true during the operation room. So cut and start to move back, but there is still space. So the oral surgeon usually worry about that. If after the surgery there is a extraction space upper and lower, he think I'm not a good oral surgeon. So every oral surgeon try to tip. Is it true or not? True. So I didn't do ASO. Okay. So in the 한국말로 하면 할 얘기가 많은데, my best friend is oral surgeon. So long time ago, I referred my patient to the upper and lower ASO because my patient has a bone problem. So ASO is best. And then send my patient to my friend, oral surgeon. But always tipping. So I asked to him, please don't try to make, but he's very, very strong guy. He never changed his mind. So always lingually tip. So I didn't cooperate with him anymore. So look at here, okay? crossbody is still here. Okay. The important thing is move the apex. Okay. 1x later, and then wow, still space here, and tongue elevator is in the mouth. Still space. Still space. I don't know why he attached this one. But anyway, the student doctor think, if I didn't jump the bite, this anterior teeth cannot move distally. And then finally, the anterior teeth will retract without any problem, but a little space at here, but look at the anterior relation become better during the retraction. And then finishing procedure, a little bit was done. In upper area, there is no approach in the upper area, just approach in the lower area. So aesthetic is not a lot improved, but let's let's see my another oral surgeon student. Okay? Class 3 and a little large tongue. Full class 3. The doctors, my student clinic name is, here is One Soul Dental Office. Okay? One Soul Chi. Midline, a little midline off, and then real class 3. and then he consult. The doctor is a woman, okay? He graduated Seoul National University and finished oral surgery program, and then he entered my school again to learn my technique. So this is patient initial, and then he explained to patient, I want to do this ASO to you. Okay, so this kind of my approach will improve your face. So she explained to her patient about the two-jaw surgery also. So this is two-jaw surgery demonstrate. So he sat with patient about treatment plan. So mandible pushing to make cross-one occlusion, lower subluminal extraction, and C-tube insertion. And then mandible 6 anterior space closure by ASO and finishing. That is her idea after conversation with patient and patient parent. Maxilla alignment and 4 or 2 anterior laminate. And the retainer is in the mandible with tongue elevator design. In upper is modified rectal retine. It is just follow my idea. I usually try to educate to my student in another university. If patient doesn't agree to the surgery, at that time, the second option, the best option, sometimes best option is like this. And the retainer is in upper area is I prefer ricket design. And in lower, I usually prefer tongue elevator design. That is my teaching contents. So she follow, okay? Even though she is oral surgeon in the best dental school in Korea, okay? And she finished and received PhD at there, okay? But she really has open mind. So enter the postgraduate master course when I worked another university, and then finished my course 2.5 years, and then this is her first approach according to my lesson. So this is very simple, but in her treatment plan, there is a whole my concept is inside. Simple, but it works. Look at mandible devious at here, and lingual arch, and start to move posterior back. This is her recording. And then anterior leveling a little bit. Control the lower anterior teeth with cuspid and push back whole posterior teeth. After that, when he tried to move this teeth back, she felt it's time to cut lingual arch. And then he controlled the space and bilateral retraction to prevent rotation. So look at the molar occlusion, almost class 1. And then place the full arch wire with open coil spring. He doesn't like to close the space during the leveling, so place the open coil a little bit. And then she did cut 2x4 rule and fix it. And at that time, she cut the sectional arch wire with like this, and then fix ligation wire. Okay, so in the middle, plate fixation, and right and left with ligation wire. Okay, and still look at here, still space. After 1 month of ASO, so midline is still off. And then in upper, she delivered clear plans to use a little L6 control, vocal lingually. So it's a vacuum, suck down plate, and place a tiny hook at here. But it doesn't work well. But anyway, she think if she use this one, it will be more good. So this, and then retraction arch wire with ball loop, but the position of loop is too distal. Okay, this in this area ball loop is better. So activation a little bit, and then she need to re-bend again. So please position just after the cuspid. Retract ball loop position is not so good, but it is a common. Anyway, she attached the full fixed in an upper to level, and then power chain, big power chain through the loop and cuspid together, because C2 is strong enough to accept all retraction force, but still a little midline is still out. Post-operation 6 months. So the phase changed a lot. And then control all kind of space with upper and lower. Now the midline is almost done. This is final result. Okay. Full teeth in upper and lower. A little uncomfortable occlusion, but I think this is good result because she is oral surgeon and this is first approach. So after the finishing, laminate, line up a little bit and laminate, okay? So that's good. So we have some kind of different, we need to think about. Yeah? It's 2017, okay? So a long time ago. Now, maybe someday she'll meet you. She can meet you because my best student among to me, okay, always say goodbye. I say hello to me, okay. So she works in the another part of 경기, 인천 area. So you can do it. So please select good patient, okay? So this is ASO. So all teeth is in mouth, and then the face changed a lot. Occlusion is good. Okay, let's think about class 3 orthodontic surgery. Extraction upper premolar and lower premolar. Okay, and then cut upper and lower. That's a normal. But sometimes it will get more good aesthetic, but functionally, I don't believe it. Long time after. Okay, I will finish the lecture at here, and then this is one part of biocreative surgical approach. This is only one part. We have 5 different styles: type A, type B, type C, type D, and type E. So today's topic is talking about type D, mandible cut only. So in the upper area, ASO is very dangerous approach. Do you understand? In upper, ASO is really dangerous approach. Okay? In mandible, ASO is not dangerous approach. So I prefer to retract upper with just cautery because, okay, ASO is really difficult and dangerous in upper. So type A is a patient try to get more aesthetic face. At that time, upper effective retraction of upper is good. At that time, we call it type A, upper corticotomy only. Okay? The reason why we involve corticotomy or ASO is there is no movement in the adult. When we extract first molar, okay, let's say class 2 division 1. So we plan to extract upper first premolar and try to retract upper anteriors. But at the beginning, it start to move back. And someday it will stop. No more movement. Okay? The doctor tried to retract 6 anteriors, but the movement stopped because of bone biology. And then clever orthodontist tried to persuade patient, your teeth is not move anymore. So it's better to make space control by tiny prosthetic work, okay, or sometimes implant at here, okay, but patient didn't accept. That is, so you need to understand why at the beginning movement, but in the middle stage, there is no more movement. Why? The reason why you need to understand that is the human biology. So the first clever doctor tried to control the space by another approach. It's more reasonable. But another doctor tried to more strong force to the anteriors to close the space. It will create root attack. Okay? And sometimes very linearly tipped result. Okay? So if we extract the premolar with a half size, it is more good to the adult. Okay? So retraction of anteriors is very limited in the adult. So extraction space 7 millimeter at here, 7 millimeter at here is too large to adult. So if we cut premolar half, it's good. So half retraction is reasonable, but full retraction is not reasonable to the adult. So if you want to full retraction at that time, you need to control bone structure. Okay? So the best approach in the long time ago, from the long time ago, is corticotomy. Okay? So intentional scarring of cortical bone has a long history, more than 100 years, more than from the Europe. So we accept that. Okay? So intentional scarring, you need to learn intentional scarring. So type A means intentional scarring in the upper. Type B means intentional scarring upper and lower. And type C is intentional scarring of upper and lower ASO. Type D is lower ASO only. Type E is intentional scarring in the upper posterior to improve open bite. So we divided 5 different approaches, and then the corticotomy through the a small bar. Sometimes cotomy by piezo machine is possible. So surgical approach, we have a very, very different style. 시간이 없네. 12시간. 그러니까 내년에 관심 있으면 또 하고. Okay? Okay, I'll finish my lecture. 자. Good result after the surgery, okay? Plastic surgery, including the genioplasty, okay? Open lower ASO. But there is a starting of root resorption. And this is another situation after ASO, the necrosis. Okay? So no bone at here. So we have a very, very long history. So orthodontics always has a limitation. Okay? Just aligning, there is no limitation. Okay? Retraction, it has a limitation. Okay? This kind of movement is no limitation, even though patient is old. Okay? Only the difference is speed. Okay? But this kind of movement is a limitation. It will go out the road. Okay? So during the road, there is no limitation. Okay.